Release, may I start?
You're welcome.
Good evening, ladies and gentlemen and fellow colleagues. Thank you for joining me this evening. Tonight, we will be engaging with two representatives from the Government Employees Medical Scheme, or GEMS, to educate us on the impact of fraud, waste, and abuse on medical schemes. SADA and GEMS have always shared a sustainable long-term relationship in which there is a platform for open communication and sharing on matters that affect both parties. On that note, I would like to extend a warm welcome to Mr. Ishmael Mogapi, who serves as Senior Manager Operations Risk at GEMS. Before joining GEMS, Ishmael held various strategic managerial positions in the health administration business, where he advised and coordinated the fraud risk management activities of several medical schemes. In addition, he has over 20 years of law enforcement and risk management experience obtained from various positions he held in both the public and the private sectors. He holds postgraduate legal qualifications and a strategic leadership qualification from some of South Africa's leading academic institutions. Our second speaker for the evening will be Dr. Pardon Maluleke, who currently holds the position of Clinical Executive of Stakeholder Engagement at Dennis. Dr. Maluleke completed his bachelor's degree in dental surgery at SMU and worked as a private dental practitioner around Gauteng province for a period of 12 years. He also worked as a sessional dentist in the West Rand Oral Health Clinic. His postgraduate qualifications include public health, bioethics and health law, and business administration. Dr. Maluleke has been employed in the managed care environment for almost 15 years, where he worked for different managed care organizations. He is currently the chairperson of the BHF Dental Advisory Forum and is also an honorary lecturer at the Department of Community Dentistry at WITS. Before I hand over to our two esteemed speakers, I'd like to go over the house rules. Please refrain from using the raised hand button. You may type your comments and questions in the Q&A tab below. We will have a question and answer session at the end of the presentation. The event tonight qualifies for one clinical CEU. CPD certificates will be loaded onto the SADA platform, and you will be able to access all your certificates under your member profile. If you are not a SADA member, you will be able to create a profile for yourself and access your CPD certificates. We are streaming live on YouTube for those who have difficulty in accessing the Zoom platform. Please remember to complete the evaluation after the webinar so that we can use this information to improve our webinars in the future. Just a reminder of our upcoming SADA events. Join us on the 6th of July for a dental assistant evening with Dr. Janelle Algemood and Mrs. Melanie Savides. On the 8th of July, SADA and the South African Dental Therapy Association will be discussing occupational health and hazards in dentistry with Dr. Rajeshri Mudli. On the 14th of July, join us for a Henry Schein evening with Dr. Biolchi discussing colors and light in dentistry. So without further ado, let me hand over to our first speaker for the evening, Mr. Ishmael Mogapi. Mr. Mogapi, you can now start sharing your screen.
Thank you. I'm going to now share my screen. I seem to have lost my presentation.
No problem.
I'm seeing everything else except my presentation. I'm just going to quickly close. Let's just make sure that I've got everything here. Oh, pardon, can you share it on your side? I'm having this. Oh, there we go. I've got it now. All right. Dr. Pabu, can you see the screen?
Yes, perfectly. Thank you.
Okay, thank you. All right. Yeah, good evening, everyone. And welcome to this SADA GEMS engagement. We appreciate this opportunity as a scheme because of, I think, on previous engagements that we've had with other SARA leadership, is that we're looking at building a strong partnership with the association. As you would know, that there's been a lot of things that has been happening in the medical aid industry. To mention the Section 59 inquiry, which basically also the findings, although and in the interim, has indicated that there's a disjoinder between medical schemes and practitioners. So this is a good opportunity for us to start engaging with the association. The aim of this presentation is basically not to tell you of what is wrong, but basically so that you can understand the impact that fraud, waste, and abuse is having on the medical aid, the benefits, and even on the providers and their reputations. But what can we do collaboratively to minimize the impact of this pandemic, if one would mention it, fraud, waste, and abuse? So from our lecture to today, where we're going to be looking at the concept of fraud, waste, and abuse and its impact, basically in the medical aid industry. And then I will ask Dr. Palin just to take you through the claims review process, which will include coding and some of the case studies, so that you can see the work that goes in the background when we are actually doing claim risk management. Fraud, waste, and abuse obviously is recognized as a major challenge for the healthcare system globally and in South Africa. I mean, you can see the figures there. In the US, it accounts for about 600 billion, amount that are spent and which are as a result of fraud, waste, and abuse. In the UK, they're looking at about 1 billion. South Africa, it has not been really quantified, but from some of the engagement that we've had in the past, it accounts for about 5 to about 20% of the general expenditure in terms of healthcare in the industry. Some accounted to about 22 billion. So it's a global problem. And I think the next slide talks about why do we say fraud, waste, and abuse, and it's very important to differentiate between these three concepts. Fraud, it involves intentional deception, misrepresentation of false statements or false representation of material facts, obviously for the prejudice of the other party. And one also looked at what is waste and abuse. And I think it's very important as an industry to differentiate between all these concepts because each is treated differently in terms of from a risk management control perspective. The waste has been defined as the extra cost incurred when healthcare services are overused or when bills for services are prepared incorrectly. Unlike fraud, waste is usually caused by mistake rather than illegal or intentional wrongful actions. And abuse, these practices that are inconsistent with sound fiscal, business, or medical practices, and as a result, an unnecessary cost to medical schemes or in reimbursement for services that are not medically necessary. Like I said that the primary difference between fraud, waste, and abuse is the intention of the party. And I think this definition has come across from the charter that we have as an industry, which was signed with associations. That was 2 years ago when we had a meeting which was commissioned by the Council for Medical Schemes. And we had pleased that we should not handle our work or behavior by service providers as either fraudulent. And it's very important that you make these distinctions when you're dealing with matters relating to claims irregularity. So this slide talks about the tactics employed to defraud medical schemes. Waste and abuse, as like I've said, is not always perceived as serious as fraud, but it's a significant financial burden on the scheme as well. Most cases that we found to be of a fraudulent nature, we normally report those to the South African Police Services, and they are also reported to the HPCSA. So some of the examples that one can is code manipulations, charging for more expensive procedure by billing for tariff codes with a higher monetary value, or charging for codes in respect of services not provided. Basically, when you submit those claims, you're making misrepresentation. Submitting accounts for services not rendered in return for cash payment to a member. Merchandise substitution, providing a member with a nebulizer and charging for an oxygen tank. Generic instead of branded, because there's obviously a monetary difference in this respect of these items. Whereas abuse, as an example, billing for unnecessary services, upcoding, unbundling costs to get more payment, excessive charges, and from a waste perspective, unnecessary admission, high cesarean rates, over servicing. I think the lecture, when we get to Dr. Pardon, you'll see specific examples that relate to this discipline in the dentistry. So there are role players in terms of these things. Service providers, false claims, irregular billing, excessive billing, like I've indicated, duplicate claims, what members, how they partake in this irregularities, the non-disclosure of pre-existing medical condition, card farming, giving your card to a sibling who's not registered to a medical scheme, so allowing a friend, neighbor to use your benefits. Employees, false claims, and these are internal, channeling members' refunds for claims to own accounts if there's refunds and directing them to their own accounts. Brokers, false medical schemes, non-disclosure of applicant pre-existing medical condition. Collusion, which is a serious issue that GEMS is currently faced with, excluded benefits or non-medical attempt claims as covered benefits. Cash plan related fraud, hospital colluding with independent allied service providers. In the dentistry space, that's what we have seen from a collusion perspective, is obviously, people submitting claims for, golden lace, stars, and the likes, which are excluded benefits from the medical schemes perspective. But members, they know they don't pay anything for those. Syndicates, identity theft to submit false claims. Syndicates build a high profile to defraud other products. What we have seen now currently is practice hijacking, and this is conducted by this syndicate. You might have your own practice number and working for a state department, not aware that your practice number is being used by these syndicates to channel claims. And we have uncovered a lot of those things. And even with the claims runs that we are doing, we keep on seeing those syndicates or practice hijacking that are occurring. So I'll urge you, just if you have a practice number that you are not even using, you are welcome to check with GEMS if whether there's been any claims that have been submitted on that practice number to see if whether it is being used. They use sophisticated ways in terms of hijack those practices, and they know who is no longer submitting claims to medical schemes. So hence we mentioned that there are types of offenders that we encounter on a daily basis. So from a South African perspective, in terms of the implication of fraud, like I've said, from even if you Google this amount in terms of, it was mentioned in one of BHF forums, we estimated as about 22 billion, the fraud that is currently happening in South African's perspective. So money spent on fraud means that there is less money to spend on healthcare expenses, and the cost of private healthcare continues to escalate with above inflationary increases per year. Statistics from SAMA showed in 2000, approximately 150 of a member's average contribution went to covering fraudulent activity experienced by the scheme. This increased to approximately about 400 in 2010 and has continued to increase to the present day. This shows a significant impact on members' contribution. If members select that option is no longer affordable, they are forced to buy down or leave the scheme and join the public healthcare sector. And we know that the public health sector is overburdened and under-resourced. So why is it so easy to commit fraud, waste, and abuse? The high complexity of the sector opens up the whole system to abuse and waste, whether done intentional or not. We're sitting here today, and some of us do not understand the codings. I'm also going to learn every time things that which codes cannot be used with this one. There's multiple schemes. Everybody's got their own tariff files, which one has to learn. So those are one of the challenges: the complex tariff structure and rules. Hence, we have bureaus that are assisting, some of the providers. There's millions of claims lines that are paid by medical schemes, and it's not possible as a scheme to look at each and every claim that comes in. Hence, the act itself that we pay in good faith and allows us to conduct reviews to see if whether the claims that have already been paid, we can validate them. We have almost 40,000 active providers. There's about over 67,000 diagnosis codes and about 87,000 procedure codes. So that is the complexity that we find ourselves in, and which basically people, some, as you would note, that they erroneously or mistakenly use different codes, and they don't intend to defraud the schemes. But some of their conduct can be seen as wasteful or, in certain instances, abuse. So this is both direct and indirect costs associated with it, usually impacting the member more significantly than anyone else. So medical aid member perception is seen as a grudge purchase. What we find is that especially members who participate or who collude with providers, and you must understand, we have seen that there are what we call runners. These people, what they will do, they will recruit members that bring to join the scheme, and this is one of the schemes that we've uncovered in another province that I would not mention at this stage. But what we have uncovered is that members pay a joining fee of about 350, and every month the member gets a certain amount, about between 1,000 rand and 1,500. And members told, do not worry, you'll get statements, ignore them, and claims are submitted. What we have seen is that this syndicate is operating from far as KZN to Malamulele in Limpopo. And through analytics, we're able to detect that, but it's impossible that you see a large concentration of certain members from a specific government department consulting with a specific service provider outside their province. And this is some of the things that are done. But when you engage these members and ask them, why are you doing this thing? They say, no, because I pay the medical aid and I don't use the benefits. Hence, you will see around about the fourth quarter of the year, claims, especially in the dentistry space, they're quite high. Some people are rushing to finalize or finish the benefits, not because sometimes it's clinically required, but they rather go there. And some of them are genuine services that are rendered, some not. And hence they say fraudulent providers or activity would not affect me. I don't need to get involved. So this is why this perception, why members commit some of this fraud or collude with certain providers. Now, these are associated or indirect costs related to fraud, waste, and abuse. The direct cost of fraud, waste, and abuse to the scheme would be the benefit paid out which was not due to the provider. It causes financial drain on medical schemes. As a result, we have to implement system and hire a team of professionals who will have to help us with preventing and fighting fraud, waste, and abuse. And from a system perspective, I mean, you would have heard the Section 59 inquiry that the scheme uses different algorithms which they use to identify fraud, waste, and abuse. And rightly so, like the Section 59 indicated, obviously there's no race. In fact, they were using numbers or practice numbers to identify these anomalies and irregularities. And we use, data analysts, we use actuaries, highly sophisticated people to detect this. So, and as a result, from a administrative perspective, these are costs which could have been used better, in terms of member benefits. Other factors is that a significant legal cost in order to pursue some of the criminal matters to obtain a verdict of fraud against the providers. We also use field workers who will go and obtain affidavits from members to uncover some of this collusion or syndicated fraud. They can travel as far as I've said, all the corners of the 9 provinces of South Africa, just to go to look at the modus operandi around this illegal or irregular behavior. And some of these matters are defended. We do also have to pursue recoveries on some of them. You have to appoint attorneys in this respect to go and recover those amounts, because in terms of the medical scheme act, these are member benefits which needs to be protected, and we need to make sure that those are recovered. And then the worst one is the removal of some of the benefits. I mean, if you can see that certain benefits are being abused, the scheme might, take decision that you cut back, or we can look at those benefits that they are not necessarily required. And we have seen a lot of those. And I must say, I've seen the recent investigation in another province where members have a hearing deficiency, and which in fact is not a case. But when our forensic guys were on the field, a provider was running to different members to give them a hearing aid to say, look, there will be people who will be coming to confirm if whether you've received this device. Just show it to them. Once you've talked to them, come to just give me a call, I'll collect it, and he will give it to another member. So this is now, when you look at it, are members actually requiring the service? Because if you look at the numbers, you can see it's quite high that they have some hearing deficiency, which is actually not a fact. And these are the things that we are faced with when we go on the ground. Now, when we do benefit design, we consider these factors, the abuse, and it's on all disciplines. I mean, installs, Dr. Comfort shoes, things that members are enticed to come into these scams. Yeah. All right. I think that is the completes my session relating to the impact of fraud, waste, and abuse. Then I will allow my colleague, Dr. Pardon Maluleke, just to take us through the next coming sessions in terms of what goes into the work of reviewing, claims irregularity from a risk management perspective. Dr. Maluleke?
Thank you, Mr. Mogapi, for
Yes.
that presentation. I'm sure it's going to be very relevant to our members. I'm now going to hand over to Dr. Maluleke. You can now start sharing your screen for the second part of the presentation.
Thanks, Dr. Pabuz. Thanks, Ishmael, and good evening, colleagues. So Ishmael has provided an overview in terms of what fraud, waste, and abuse is. And further than that, also shared in terms of the impact. I'll focus more on some of the activities that we focus on in terms of dentistry, with a view of trying to answer some of the concerns or the questions that you might have as practitioners. But secondly, we'll also share with you some of the concerns that GEMS has. Obviously, one of the strategies that GEMS emphasized on is provider education, obviously with a view of changing claiming behavior and improving the relationship between practitioners and the scheme. So I think as a practitioner, one of the questions that you probably have is, how do I probably get identified as one of the dental practitioners to be engaged by GEMS? So there are three things that actually assist us. One of the things that we do is an internal report. Secondly, there are queries from different stakeholders, and I'll talk to this in the next slide. And lastly, it's our risk management tool that for each and every claim, we actually save on tooth number per beneficiary. So that also assists us in identifying any irregularities. Now, in terms of internal reports, so the scheme does reports at different times, either on a weekly basis, monthly basis, or on a quarterly basis. And again, when these reports are done, practice number are used. So it doesn't tell you who the provider is, it only gives you their practice number. Now, our second identifiers are queries. So it's either queries from members, queries from providers, and at certain instances, we also get HPCSA tip-offs. Now, from members' point of view or patients' point of view, in most instances, we get complaints and queries from members who, for example, will say, you know what, I don't know this provider. I've never consulted this provider whatsoever. Or a provider might say, I have consulted this provider, but I do not agree with the cost of the treatment. Or members might say, you know what, I have visited the provider, but I don't understand the treatment that was actually done and was actually claimed. So our members or our patients are getting educated. They query some of the treatment that are provided. So this actually raises the question in terms of patients education, making them understand the procedures that are actually provided and the cost thereof. I know the issue of cost is a problem when it comes to dentistry. We don't want to discuss the cost related to treatment, but it raises question, and members are actually asking these questions. From a provider point of view, this happens a lot where providers operating in the same area or in the same town, one provider complain about the other. So we do get tip off where a provider A say, you know what, provider B is doing A, B, C, D. And when such things happen, we are bound to actually follow and investigate them. In other instances, as I said, we either get tip-offs from HPCSA or follow up on cases that will pick up that HPCSA is actually working on. But on the issue of providers, again, complaining when, for example, a provider will submit a claim, let's say, for example, for a restoration on tooth number 37, and we reject the claim and say this tooth number has been extracted by provider B. So that actually raises a complaint from provider A. And obviously we need to follow up and check exactly what's happening. Can move to the next slide. Now, this is just to share with you in terms of our engagements that we have had with providers in 2020. And maybe at the outset to say, by and large, most of the providers we don't have concerns with. It's only a minimum number of providers, and I'll break it down to you. For example, in 2020, we had 3,998 providers who were claiming from GEMS. These include all dental providers of different disciplines, excluding hospital and anesthetists. Now, we profiled 1,797 providers. So profiles is done on each and every claiming provider, whether there are any queries or not. So generally, all providers will get profiled if you're claiming from GEMS. But out of those, only 18% led to a detailing profiling. So there were a few concerns here and there. And that actually necessitated further profiling. 60% of those, the profile made sense. So they were actually discarded to say there's no concern in terms of this provider. So that's 60% of around 1,797. Only around 4.8% of all claiming providers records were requested. So that translates to around 194 providers. Again, there were providers where we needed to do further analysis. In total, this amounted to 13 providers. So it's around 0.3% of all the claiming providers. Over and above that, we had around 24 providers where we had what we call peer-to-peer discussions. So all in all, out of 3,198 providers, only around 37 providers were engaged by GEMS in 2020. So again, it underlies the issue that it's not that there's a general concern with all providers. It's only a few number of providers that we engage on a regular basis. Now, on coding, as I said, we want to share our concerns with a view to improve claiming patterns, obviously to enhance our relationship with providers. Now, the first concern is the use of tariff code 8104. So, as we all know, 8104 is very clear that this is for a specific dental consultation. But what we have seen over a period of time is that we have noticed where providers use 8104 for procedures where subsequent visits are required. For example, if somebody went for a preparation of a crown and need to come back for further visits, then certain providers will use 8104 for those subsequent visits. Another example, root canal treatment, you do your preparation. When they need to come for obturation, then certain providers will claim for 8104. And in our understanding, that's inappropriate, because 8104 is only supposed to be used for instances where somebody consulted for a specific purpose that was not part of your initial diagnosis, your initial treatment plan. The second concern is around the use of sedative filling. Here we picked up that some providers or dental practitioners will want to use sedative filling as part of your restoration. So for example, we are doing a 3-surface restoration. So they'll want to claim for a sedative filling with tariff code 8369 or 8353, depending on whether you're looking at an anterior or posterior tooth. The third concern is around the use of tariff code 8176, periodontal screening. Now, again, I'll refer to the guidelines. So 8176 is very specific again that at minimum you need to do your periodontal charting for the full mouth. Secondly, this needs to be accompanied by your bleeding index and plaque index. Now, our challenges are in twofold here. Firstly, it's either there is no recording at all of all those three clinical indices. So there's no recording of periodontal charting, there's no recording of bleeding index, and there's no recording of plaque index. Where there's an attempt to actually do some recording, you only find your periodontal charting. The other clinical indices are not recorded at all. The fourth concern around coding relates to the use of tariff code 8166 and 8167. And the description are there. So your 8166 is application of desensitizing resin per tooth versus the application of desensitizing medicament. And the challenge here is that providers, either deliberately or otherwise, where they have applied desensitizing medicament, they'll claim for desensitizing resin. And obviously, because that is claimed per tooth, unlike your desensitizing medicament, which is claimed per visit. And again, as I said, we're sharing these concerns so that we can actually improve on claiming patterns. Next one is the use of provisional splinting, tariff code 8725. There are certain providers who, for example, routinely claim this with scaling and polishing. On further engagement, the reason provided is that sometimes when you do scaling and polishing, the teeth become mobile. But on review, we'll find that it's only certain practices and for most of their patients. And it's just scaling and polishing followed by provisional splinting, no further periodontal treatment whatsoever. The next concern is on the use of diagnostic photograph. And our understanding is that these are used mainly for diagnostic purposes, as the description says. However, we picked up that on certain practices, this will be used routinely for every consultation. And these are mainly used for educational purposes by these practices, not necessarily for diagnostic purposes. The next concern is on infection control or tariff code 8109. So you'll remember, colleagues, that GEMS was one of the schemes that was first to increase the fee for 8109 when COVID-19 hit us last year. And this obviously was to assist providers, in terms of covering the cost for PPEs. So what we want to highlight here is that while GEMS has done that, generously, it's important that we claim correctly. We make sure that we use 8109 multiplied by 2 where we've got a registered dental assistant. That is the concern. The next concern is around the use of ICD-10 codes very vaguely. Now, ICD-10 codes are diagnostic codes. They provide diagnosis. So as a funder, you want to be able to determine the burden of disease. So you need ICD-10 codes that specifically will tell you what type of dental caries you're dealing with. In most instances, we find that providers just give a general ICD-10 code for all their patients and for all different dental caries, and that creates a problem. And lastly, the issue of scope of practice, as Ishmael said. So provision of gold inlays is still a problem. And now the concern firstly is that obviously for dental therapists and oral hygienists, more specifically dental therapists, so this will be provided, and obviously they'll pay dental laboratories cash and find a way of claiming from medical aid. The same with dentists, so it will be claimed and find a way of claiming from medical aids. So as I said, that in certain instances, we we will get records from providers. So we also have a concern in terms of record keeping, where in our view, we think that this is not in line with HPCSA guidelines. So you find that some information is removed. In certain instances, correction fluid is used to alter records. So you can see clearly that these records have been altered, with some kind of correction fluid. Additional entries are not dated or even signed. Sometimes you find that different patient notes on the same records, the same patients, and on one patient sheet, you've got different patient notes that are actually written. So this is something that you also need to pay attention to. So I think the next logical question would be, why would we request records from dental practitioners? Now, Ishmael mentioned that generally medical aid schemes pay claims in good faith. There are certain instances where a funder will want to verify claims. Two examples: one is the issue of tariff code 8176 that I mentioned before. If on those instances we didn't ask for records, wouldn't have picked up those irregularities where either those clinical indices were not recorded at all, or there was some attempt to record them, but not to the extent that is actually required. But secondly is the issue of tooth chart, where we pick up that, for example, a practitioner A, we want to claim for a restoration or a filling, but our system says, you know what, this tooth has been extracted by practitioner B 2 or 3 years back. And we pick this up a lot. And when we pick up such instances, we need to ask for records to verify exactly what's lying between practitioner A and practitioner B. Because if A provides an X-ray that says tooth number 36 is still there, but practitioner B claims I've extracted tooth number 36, 3 years, then it creates a problem. But when we request such information, we don't ask for medical information or personal information. All that we're asking for is simply dental charting, dental records. What was your diagnosis? What is the periodontal charting in instances where we are looking at tariff code 8176? In certain instances, yes, we'll also ask for X-rays because that will assist us in making a determination in terms of whether a particular tooth is still present or not. And as I said, we don't request medical or personal information. Another concern is the use of radiographs. So we picked up that almost 20% of all claiming dental practitioners do not claim for X-rays. So if you break it down, 13.4% of dentists that are claiming from GEMS are not claiming for X-rays whatsoever. Dental therapists, 59.3% are not claiming for radiographs. And oral hygienists, around 74.2% are not claiming for radiographs. And I think the question probably that they'll be asking is why is it a concern for GEMS that some providers are not claiming for X-rays? And obviously the concern is about the quality of care. It's about clinical outcomes. I think you'll agree with me that if you were to provide appropriate treatment, you need to have an appropriate diagnosis. And X-rays are your basic, dental X-rays are your basic diagnostic aids. And obviously it raises the question in terms of diagnosis of your interproximal caries, the depth of dental caries. But again, most importantly, the issue of periodontal disease. Are we not short paying our patients if we provide dental treatment without the use of the most basic diagnostic aids. So there are a few cases that we want to share with you, three in total. So on case number one, where the arrow is pointing, so we use different measures, you know, to as I said, to profile providers or review claims, and based on that, we for example say that provider on the error is an outlier. He or she is not fraudulent, but it's an outlier based on the measures that we're actually looking at. Now, once we have done that, then we plot this particular provider against the peers in the same area or in the same province. So on your right-hand side where you see, I'll use brown. So you've got a brown color, you've got a blue color. So the blue color is the provider or a specific practitioner that you're focusing on. The brown color is the peers around the same area. And here we are looking at three measures. So the first measure that we're looking at is the number of patients who required restorations. Secondly, we looked at the patient who actually received x-rays. And the last measure is the percentage of patients who actually needed 3 or more fillings. Now, you'll see that at the top of the triangle, where we look at the number of patients in need of fillings, 100% of patients who attended this practitioner walked away with dental restorations, compared to 80% in the same area. When we look at the second measure on the right-hand side of the triangle, the number of patients in need of 3 or more restorations. For this particular practitioner, almost 90% needed 3 or more restorations. Now, the last measure is the number of patients who actually received x-rays, or the percentage. You'll see that for this particular provider, 0. So none of the patients actually received x-rays, while 100% of the patients walked out with restorations, 3 or more restorations. The second case study again, we looked at the provider and compared the provider with the peers in the same province. So you can see where the arrow is pointing. Again, your first measure says this particular provider has the higher cost per patient. It's an outlier. The provider is not fraudulent, but it's an outlier. Now we compare the provider with the peers in the same province, again, looking at the same 3 measures. Again, for this particular provider, 100% of patients walked out with restoration compared to around 80% of the peers in the province. When you go to the second measure, that looks at the number of percentage of patients who required 5 or more restorations. So you're looking at around 85% compared to almost 0% in the rest of the province. So it means that in other practices, probably the other patients had 3 or 4 restorations, but for this particular practitioner, it was 5 or more. Again, we look at the issue of radiographs. We compared this particular practitioner with the rest of the province. Again, for the province, you can see it's above 25%, but for this particular practitioner, 0. No x-rays whatsoever. The third case study relates to laboratory, and it actually relates to the issue of scope of practice and the use of and the provision of gold inlays and dentures. So we'll all know that dental laboratories are allowed to claim directly from medical aid schemes. And what normally happens is that dental laboratories will bill when they've actually completed the prosthetic or the appliance. Now, as a dental practitioner, then you will bill once you have actually delivered the prosthetics, or if the patient doesn't come back, then you bill for the laboratory. Now, as we said again, claims are paid in good faith. So at face value, you will not pick up any irregularities unless if there are duplications, which then will get rejected. So we focus more on retrospective review. After a long period of time, we go back, we monitor claim, look at different analysis. Now, so for this particular dental laboratory claims, we picked up a high number of these laboratory claims had no dentist claims associated with. So the laboratory has been paid, but there's no clinical code, obviously, because dental laboratories can submit their own claims. However, again, on analysis, we picked up that some of the patients had visited dental therapists. So they are not dentist visits, but they visited dental therapists. We could not find any work requests or invoices on record. Well, the dental laboratory admitted that, on a number of occasions, he or she has provided small dentures for friends and family. When we requested further information, it was not forthcoming. So the next step was what we call claims verification process, where then members were called to ascertain what actually happened. So some members will advise that they've actually visited the dental laboratory directly and were provided with dentures. And obviously, we all know that laboratories are not supposed to consult patients directly. In certain instances, members confirmed that they had gold inlays or crowns. But again, no name of dentist was provided. And lastly, some confirmed that they had denture claim, but they could not confirm whether they actually received a denture or not. But they have seen a claim for a denture. So these are some of the things that we actually see on a regular basis. So in closing, colleagues, I think that there are three areas that as a profession we need to start thinking about. The first one I've spoken a lot about, and that's the use of X-rays. But in doing so, we need to balance the need versus the overprescription of X-rays. And as I said, the lack of use of X-rays raises questions, especially on practices where you see a high number of multi-surface restorations, but there are no X-rays whatsoever. There are no history of X-ray claims, both in anterior and posterior teeth. And again, it raises a questions in terms of diagnosis of periodontal disease. And lastly, interproximal dental caries and death of dental caries. But having said that, again, I said, then we need to balance this with overprescription. And I'll give you a scenario. You've got a 30-year-old that on a 6-monthly basis visit their dentist. All that they get is scanning and polishing and X-rays. No restorations provided. And every time this particular patient visits a dentist, again, is scaling and polishing, no restoration, maximum chargeable X-ray are charged every time and then. Then it raises the question that is this based on the need of the patient? You know, the type, the frequency, or the number of X-rays provided. Are they really based on the need of the patients based on consultation? Or is just a routine practice by the provider that every time this particular patient who does not present with any sign of dental caries or periodontal disease whatsoever? The second issue is the impact of the phenomenon of restorative cycle, where it starts with you know, brown marks on the occlusal of a teeth, and because of, you know, improper diagnosis, we go in, we drill and place a two-surface restoration. Over time, development of secondary caries. This is followed by root canal treatment. Then it requires, you know, post, core, and crown. And the question that I want to ask is this. All these teeth that we restore, do they really need restorations or not? I think that's the question that we are trying to raise. Or maybe ask it differently, that if there was no incentive to place a restoration, would I have played a restoration on that particular tooth? And the last issue that we want to leave you with is the issue of risk-based dental consultation. And again, I'll create a scenario. A 30-year-old patient visits their dentist on a 6-monthly basis, receives scaling and polishing, no restorations, X-rays are taken. So in a way, it says this particular patient is dental caries free, no periodontal disease. Is it not time to start adjusting the frequency of a visit for somebody who's dental caries free and does not present with any signs of periodontal disease? Shouldn't we start adjusting the frequency based on the history, the risk, and the oral health status of all our different patients? Because you've got practices that 6 months or 7 months, they see the same patients getting a polishing, no restorations, no periodontal treatment whatsoever. That's the end of my presentation.
Thank you so much, Dr. Maduleke, for that informative presentation. I think we can move on to our Q&A session now. We have quite a few questions. So on our first question, the attendee asks, what impact does internal senior management theft and misappropriation have on the funding of healthcare to the members of GEMS?
Dr. Pabu, may I request
Yes.
you just to repeat that question, please, for us? Sure,
no problem. What impact does internal senior management theft and misappropriation have on the funding of healthcare to the members of GEMS?
Okay. Okay, thank you. Obviously, we have internal controls relating to misappropriation of funds. So we have governance, processes, especially in relating to procurement. We've got audit committee that look in terms of the behavior and performance of our senior management. Should there be any irregularities in that respect, appropriate action is taken, against any of those offenders. So we have those in place to make sure that we do those investigations and they are reported to the appropriate, regulator or statutory bodies or law enforcement, and civil action is taken if maybe there is a misappropriation of funds by any of the staff members. Thank you.
Okay, thank you for that answer. The next question asks, how do you intend managing the 6 monthly audits you regularly send out to participating dentists to validate the authenticity of the agreement undertaken by dentists in view of the new POPIA Act that comes into effect on the 1st of July 2021? Is it incumbent on dentists to disclose personal information of patients to your clerical office staff without transgression of the Act by the service provider? Sorry, you're muted.
Yeah. All right. I think, Dr. Pardon, I'm also allow you just to help me on this one. Obviously, with POPIA coming into effect, there are certain exemptions that are going to be given to some of industry bodies. In our instance, remember, we are guided by the Medical Schemes Act. And any activities in terms of any of our administrators or employees, they are bound by that act. So the confidentiality does not go away in terms of that information. Remember, for the business of medical schemes, you require such information to validate claims. The act in itself does not say that that information is no longer going to be shared, but we have taken measures to make sure, even in our administrative space, to make sure that confidential information, is going to be protected, and there's training around handling of such information. Yeah.
All right.
Okay.
Thank you. The next question asks, what is the position and implication when an employee of a service provider or practice and not the service provider itself is accused of fraud, waste, and abuse?
Yeah, we have found in many instances that sometimes even the healthcare practitioner is not even aware in terms of what these administration staffs are doing. Especially what we have seen is that some information is being shared, especially the medical details of some of the patients are shared to this type of syndicate. So in those instances, obviously the main what we will do, we'll have to open or follow it up with the law enforcement agencies by opening a criminal case against those employees, because obviously the healthcare practitioner will play a very big role in terms of assisting us with such investigation, and they will, in most instances, be exonerated from some of those irregular behaviors.
All right. Next question says, can a scheme claw back when there has not been mutual agreement between the scheme and the service provider for clawback?
Okay, one has to look at in terms of the act in responding to this thing. What does the provision of section 59 says? Like I've indicated previously, that the scheme pays in good faith. When you submit the claims, we will not say upfront we need the x-rays because of it's an automated process where claims are submitted via EDI electronically. Now, from a clawback perspective, the Act does allow us that if a claim has been paid irregularly, you can offset against future claims. That is claims reversal in those instances, and I think it happens a lot. Now, in relation to a fact where a provider is found to have submitted erroneous claims, and maybe the amount is quite high, that if you reverse some of those claims, the service providers might not be able to can receive any payment on future claims. We are allowed, in terms of the Act, to enter into an acknowledgement of debt. Now, from our side, and as you would have heard, obviously, even in Section 59, that we quantify the irregularities. We will not assume that all your claims are incorrect. We will go line by line and indicate what the tariffs, which were, like Dr. Pardon has indicated, were incorrect. And those amounts, once we've quantified, the service providers, we will look at your affordability, and we can enter into such agreements to make sure that you pay off this amount over a certain period of time. So this is the approach that we are taking at this stage. And we have looked at these processes that we do not allow service providers signing this acknowledgement of debt, which in future they will not be able to sustain or pay. Because of affordability. So when your circumstances like what the impact of COVID, most providers, they've requested payment holidays in those respects. Those are granted. If they've requested to pause in terms of deducting over a certain period, those will also be granted. It's an agreement that is entered into, and it should be mutual between the two parties in terms of the terms. So we will not bully or enforce it on any service provider. I mean, obviously, if negotiations in those respects fails, and for the benefit of our members, the scheme will have no alternative but to exercise its rights on behalf of the members, maybe even institute civil litigation in those respects. But that is in most severe cases, especially of fraud, where the provider is no longer going to submit claims. Thank you, Doctor.
Okay, I think that fully answers that question. The next one asks, do you inform your clients when you see irregularities on provider billing? For example, if a provider does an endodontic treatment without placement of rubber dam. I think Dr. Maluleke can maybe
can take this one.
Yeah, for my benefit, if you can repeat the question very slowly.
Okay. Do you inform your clients when you see irregularities on provider billing? For example, if a provider performs an endodontic treatment without the placement of a rubber dam.
So I'll assume in this particular instance the client refers to the patients.
Yeah, it sounds like it is the patient, yes.
Will not involve the patient. If it's a matter that we think is a clinical matter, we will engage with that particular provider and try to find actually a resolution or raise our concerns. So in any clinical irregularities that we pick up, we engage providers and try to find resolution to the matters.
Okay. The next question asks around audits. Does GEMS ever intend paying practitioners for the submission of audits for treatment undertaking because it takes up a lot of time, practice time and admin time?
Yeah, all right. Yeah, I do not want to quote, what the law says, especially in terms of record keeping. And obviously, the fact that even the SPCSA guidelines indicates that you need to keep records for a certain period of time, it basically means that you need to understand that the profession inherently you'll be audited over a period of time. Either by ourselves or by even SARS or any other regulatory bodies. And we do understand that it takes time for a practitioner to collate such information for purpose of an audit. And this is one of the things that complaint which was raised, and we have actually responded to that to say that let's really look at our process. If you're going to do an audit, do not do it over a period of 24 months. Because of, those records, if I ask you to get records dating back 5 years ago, it's going to obviously take your time. So you need to limit the period in terms of the irregularities. Don't make it standard. It needs to, match with the complaints or the analysis at hand. And also what we have done also now to look at the periods in which we give a provider to respond, because we do understand, like now today we are meeting in the evening because of during the day the providers are expected to serve our patients or our members. So even in those instances, we want request to say, please provide us with information relating to 2 years back within a period of 3 or 7 days. It's a dual process. Once we have been identified for a review, we will need to understand your circumstances, how long you'll be able to make sure that you comply with such requests. So we have relooked at those processes, and if maybe you're not seeing any change on our site, I urge you obviously to use SADA and any other platforms to raise this thing, because it has been a serious concern, and we have actually listened to the providers to make sure that we will afford more time. But unfortunately, we cannot reimburse you for that. Thank you.
Okay. So the next question, I think you've answered it in that one. So I'll move on. I think this one is for Dr. Maluleke. When will GEMS review their pricing structure to reflect the actual cost of providing dental services? In other words, when will GEMS use the RVU values to determine the amount that is paid out to dentists?
Yeah, so Tinesha, as you are aware, we only received the RVUs on the second of June, and obviously this took SADA, I don't know how many years to actually finalize the RVU studies. So from our side, obviously we need time. We need time to review those RVUs. We need time to do the cost impacts analysis. So we have essentially given ourselves the rest of this current year to actually undergo that particular process. So it's only in 2022 that we'll start having an idea in terms of what the impact will be. But in terms of when will that be implemented at this stage, we really cannot say. It's going to be a long process, as you can imagine. As I said, it took SADA almost 3 to 4 years to actually finalize the RVU studies.
Okay. Another question for you, Dr. Maluleke. Why has GEMS started asking for an ICON score to authorized orthodontic treatment?
So the use of ICON score is not new. It's been in place for quite some time. And obviously, WHO propagates the use of some kind of scoring when reviewing the need for orthodontic treatment. And GEMS actually opted for the ICON scoring.
All right. The next question asks, can medical aids request practitioner's notes?
I think I'll go first. Maybe Ishmael will add. I think in my presentation, I mentioned that we generally what we're asking for is chatting, and chatting is actually reflect in a way what they have already claimed for. So already we've got some kind of information on the same patient. We want to verify that what has been claimed actually correlate with the chatting. And also, we also ask for an X-ray. And as you know, X-ray will provide you with all the information that we require. Other than that, we don't require any additional patient information.
Okay.
Those are the basic information requirements that we'll request from providers.
Yeah, I think you've covered fully. Thanks.
Okay. The next question refers to, can a scheme launch a civil claim against a practitioner if they have not discharged their burden of proof that claims were subjected to fraud, waste, and abuse?
Yeah, like I've indicated as such, obviously, when we do find irregularities, and if we do look at from a definition of fraud, we will report this into the law enforcement agencies, be it the South African Police Service or the SIU. They will take this matter through the normal systems, court processes, and we will rely on them in terms of that. But now, from a civil perspective point of view, is an issue. If we have evidence that we have not rendered services, we have members who indicated that they have not seen a particular service provider, that on itself, because if you look at the burden of proof, that is used from a criminal point of view or from a civil process, we are allowed to follow, due process and in terms of institution civil action against such service provider using members in those instances. And you must understand, civil process is a two-way process. It's not us, the court is only going to listen to us. The provider also will have an opportunity to dispute the allegation that will be made against him. So in terms of the act, we are allowed to make recoveries, and recoveries you can use civil processes Thank you, Dr. Pabu.
Okay. Thank you, Mr. Mogapi. Next question asks, why does GEMS pay different benefit rates for contracted and non-contracted clinicians? Do they expect that non-contracted clinicians provide a lesser service for the same procedure?
Dr. Maluleke, that's yours. From a network perspective, will you take that one, Russ?
So obviously, GEMS will want their members ideally to consult within a network environment. So the issue of paying a higher tariff for network providers is to encourage more providers to be part of the network. And one of the issues, obviously, that we focus on is making sure that members don't have co-payments. You want their members to go to providers, and then after that, then they get charged co-payments. But over and above that, one of the benefits of having more providers within a particular network is that then you're able to look at the issue of the quality of care within air controlled environment. We don't expect the quality of care to be different for non-network versus non-network providers.
Okay, thank you. The next attendee asks, which protocol should be followed when you, as a practitioner, discover that a member is guilty of card farming?
Yeah. On our website, and hopefully we can also share this thing after or at the end of this engagement, we have a hotline, which is where you can call in anonymously and provide us with that information, so that we can investigate it. So the hotline is there to use for such reporting. And I think also from a SADA perspective, I will share the details. Even if it's shared with them, they will definitely send it to us. Thanks.
Yeah, we'll definitely do so. Our next question asks, can your internal systems at GEMS accept the recordings of different intraoral scanner software for the verification of clinical information that you request from dentists?
Yeah, I think we're able to receive different kind of X-rays and scanners, unless if there's a specific problem with a particular provider, then we can actually engage privately. But by and large, we're able to take all different kinds of scanners and radiographs.
Okay. I think this is also another question for you, Dr. Maluleke. What do you do with claims for implant placement when no surgical guide was used, making it a high risk for failure?
I think firstly, GEMS doesn't pay for implants.
Yeah. Okay, so that question is then non-applicable.
It's not applicable, yes.
Okay. Our next question, would it be possible to have X-rays come from the radiology benefit and prosthetic work come from the prosthesis benefit? And then related to the implant comment, the practitioner says that GEMS needs to incorporate an implant benefit because this is a viable and acceptable treatment form as opposed to a 3-unit bridge on virgin abutment teeth.
Yeah, so the issue of benefit, as you know, Dr. Pabu, is that GEMS on an annual basis undergo the process of benefit proposal and benefit review, where different associations, including SADA, get given an opportunity to submit proposals that the scheme can actually consider. So if there are any benefit proposals that are coming from your members, then they need to go through yourself, and then you submit through to GEMS for review. I don't want to comment on specific issues. I can, but I don't want to comment. I want us to follow that process so that we're able to provide proper feedback through SADA.
Okay. If a practitioner has been referred to HPCSA and SAPS, can the matter be settled with the scheme and then the charges withdrawn?
Obviously, if the case is with the police or NPA, the scheme has no mandate to withdraw those charges, because if they find that there's a criminal offense that has been committed, the prosecutor, once they will call them the dominus litis, they will decide if whether they're going to take those cases further or not. From an HPCSA perspective, obviously, what happens is that what is reported there is an unethical behavior. And the way in which the offenses are drafted in terms of the HPCSA is not how the scheme applies them. So in their instances, they will look at it from an ethical point of view. Obviously, if there is a settlement, HPCSA normally asks the scheme to say, okay, the provider has acknowledged that there was an irregularity, and they've agreed that there is a settlement between the parties, then they can make a decision. We normally allow it, we leave it to them, but we normally will cooperate and provide them, even if there's an AOD side, and then we leave it to them just to make those decisions, because they use different rules from an ethical perspective than from the schemes. Yeah.
Okay, I think we can now take our last one or two questions. The attendee asks, Mr. Mogapi says that we must adjust the scale and polish visits to annual visits if we see from the patient's history that this is the only treatment needed. What are we supposed to do when the patients are very Google informed and insist on 6 monthly checkups and cleanings?
Yeah.
I think that's an unfair question to Ishmael. that was my comment. We actually need to move towards risk-based intervals, and actually some of the international association actually propagate for that based on the risk of a particular patient, you can actually move from 6 to 8 to 12 months based on the history and the risk of the patient. In certain instances, some comment that we're probably doing more harm than good in seeing a patient every 6 months who doesn't present with any dental caries or periodontal disease, but we continue to scale on a 6 monthly basis. It's our role to actually educate our patients when they raise such questions.
Okay. And I think we can now take our last question. Will it be possible to publish the names of your professional staff and handle authorizations? It has come to be known that oral hygienists are making these decisions. That is the first part. And the second part is, why are these staff not available to discuss their decisions with the clinician? Surely an X-ray and some pictures cannot replace a clinical examination undertaken by a clinician.
So to answer your first question, we obviously have different levels of staff that actually deal with authorization. I think for example, we've got 3 dental advisors who actually make a decision in terms of a particular procedure need to be approved or not. But obviously, yes, you also have lower staff who then will do your indexing, will do your first line review that any dental practitioners will actually be able to do so. Now, on the second question of unavailability of staff to have a clinical discussion, I think providers do request that to actually call them back for a discussion, and when such request is made, we actually do that.
Okay, perhaps we can just take one very last question. What is the future of GEMS as a medical aid scheme once the NHI comes into operation?
Obviously, you know, what GEMS professes that we want to be the blueprint for NHI. And we are working with the Department of Health and various stakeholders in terms of participating in terms of the realization of NHI. So from a futuristic perspective, we want to play a very big role. We are there, we are ready to make sure that we can take this task and make sure that NHI is a success. So there's great participation that we are giving to the government in this respect. So from a futuristic perspective, whether GEMS will be there or not, only thing I can say is GEMS will be available to render services to the greater public.
Okay, so that brings us to the end of this evening's program. I just want to once again extend my gratitude to Mr. Mogapi and Dr. Maluleke for the valuable information that you have provided, and SADA looks forward to hosting you once again in the future. And many thanks to all our attendees as well for making the time to attend tonight. Good evening, everyone.
Thank you.
Thank you. We'll close the webinar now.